Many people say that appendicitis is one of the hardest, diseases to diagnose because the symptoms are so variable and sometimes they don't even show up. Is that something that you've seen in practice, or do you disagree with it? Or?
No, I agree with that, yes.
Why do you think it's so hard to
just because, as you said, it could be intestinal flu, it could be food poisoning, it could be a lot of different things. So there are a lot of mimickers of appendicitis. However, common things are common because they occur frequently, and appendicitis is one of the most frequent causes of pain in the abdomen that's persistent, and when associated with findings that indicate soreness, pain, guarding over the area of the appendix, that is highly diagnostic of appendicitis.
So in your career, how would you have gone about, ruling out some of the other options, diagnosing with the appendicitis, and then going on to treat it?
Age-wise, appendicitis is more common in the younger person, and if there is indications of surgical intervention needed, then I would not be highly concerned if you would find something that is surgical other than a appendicitis. And there are other things that can mimic appendicitis, such as a fishbone in the area of the colon near the appendix, or pinworm infection of the appendix, a tumor of the appendix, an abscess of the appendix, a mucocele of the appendix, or even diverticulitis of the right colon or cecum. There are many things. If it is indicated for surgical intervention, then it may be greatly benefited to be cared for surgically, even if it's not appendicitis.
So when you are getting ready for an appendectomy, generally, how long does it take? How long is the recovery?
It depends on how it's done. If it's done with a laparoscope, then generally it can take like about an hour, give or take 30 minutes, or maybe more, to remove the appendix. And they can be probably out of the hospital in about 2 to 3 days, depending on how they do.
Is there other preferred, strategies for removing the appendix other than laparoscopically?
The other ultrasound method is to make an incision, open the belly, and remove the appendix that way. And there's nothing wrong with that. That's very, very good. It may even prevent some complications from laparoscopic surgery, such as abscesses, and if you find other causes of the malady, such as a tumor of the colon or a tumor of the appendix, then you're right there and you can do it perhaps even easier than you can with a laparoscopic. So it has some distinct advantages.
Did you prefer one strategy or the other, or did it just depend on the case?
I was trained usually to do open appendectomies with an incision, so I like that very, very well, and my patients probably left the hospital same time as laparoscopic surgery, and I've seen some major complications on people that did laparoscopic appendectomies. So it's not without its risk and hazards and complications also.
What's one of the strangest cases of appendicitis that you've seen?
You must put that into that, because I hadn't seen that before.
Maybe they got people on their barbecue or something.
I had a Jehovah's Witness patient that was operated at another hospital, and the appendix was removed. The surgeon left town. The patient was being cared for by another doctor, and for some reason the doctor did a colonoscopy on this young patient. The patient then developed shock and was in extremis, and because he was a Jehovah's Witness, was referred to my care because we were Jehovah's Witness surgeons, and we knew the Jehovah's Witness brothers that would refer their patients to us for care because we did surgery without blood transfusions, which they were against. So this man, who was, I think, 16, came to the hospital by ambulance, was critically ill, had sepsis or infection, and needed emergency surgery. And after preparation and treatment of lack of fluids and need for antibiotics and stabilization, he was operated on, and shortly after he was put asleep, his heart stopped for 9 minutes, and we were able to get his heart going again by administering adrenaline into the heart, and he was intubated before the operation started. And we found with surgery that we commenced following his resumption of his heartbeat that his appendiceal closure had blown open, and he spilled fecal material and colonic material into his abdominal cavity, causing multiple abscesses and peritonitis. We cleaned all that out, washed it out, put in drains, repaired the appendix closure, and this patient ultimately was able to leave the hospital, but was initially paralyzed and blind, and gradually got better with physical therapy, and was able to leave the hospital. And then a few years later at another hospital, I was asked to see a patient about a bowel obstruction, and it happened to be the same patient. And one of the big things that I noticed the first time I went into the room to see him was that he was watching television, and whereas he had been blind before, he regained some of his vision. He was able to get a restricted driver's permit to drive to work only in Wentzville, and it turned out that he didn't need any additional surgery, and his bowel obstruction was treated and was relieved. His family was very grateful for our care for him previously, and I think at this time he was now 19 years of age or so, and it was one of the most outstanding cases that I was ever involved with in regard to appendicitis.
Throughout your years, you worked on hundreds, if not thousands, of people and saved many lives. What was your favorite part of your job?
What was my what?
What was your favorite part of your job?
I enjoyed working. I enjoyed being with patients. I enjoyed my staff at the office. I enjoyed my anesthetic doctors, my anesthetic nurses, and I enjoyed the nurses on the floor and my aides, and I look forward to every day was another great possibility of seeing something you hadn't seen before. Almost every day I saw something I hadn't seen before. If I could see 10 patients every day, 7 of them I could probably find a need for surgery, like a hernia, hemorrhoids, a breast tumor, an ulcer, a phlebitic leg, a skin cancer, a goiter. Just by looking at them and listening to their history, many of them you could make the diagnosis with just the history, physical and keen observation and examination of the patient. So every day was a new day. You turn another page, you didn't know what was going to be on the page for tomorrow, and it was always great to look forward to seeing another day.
What was your favorite procedure that you did?
Well, probably hernia repair. Right? We did a lot of hernias. We used a lot of mesh, put in some plastic mesh, and gradually got better and better as the years went on with our hernia repair. We became more successful, more proficient, and it was very rare that we ever saw a recurrence in a groin hernia, inguinal hernia. We had more recurrences on hernias that were post-operatively related to previous surgeries, particularly in the upper abdomen. But the one I liked probably and did the most of was groin or inguinal hernias.
Thank you, Grandpa.
Okay, Jim, got your time?
Yep.